start our second part of our review course for the day. We are honored by the presence of Dr. Omar Al-Gabi. He's not unknown to all of us. He is a member of our society. Dr. Al-Gabi, for those who do not know him online, has been working mainly on rheumatoid arthritis. His medical service included psoriatic arthritis, ankylosing spondylitis, metabolic bone disease, vasculitis, lupus, and related inflammatory disorders. Dr. Al-Gabi graduated from Ain Shams University, Cairo, Egypt. He got his fellowship of the Royal College of Physicians of London. Then he got his master's degree of science in rheumatology from Kellogg College, Oxford University. He got also his medical doctorate from Cairo University. Later on, he got another diploma of internal medicine from the Royal Postgraduate Medical School in Hammersmith Hospital, London University. And he also got a Master of Science in General Medicine from Ain Shams University. Dr. Al-Gabi will will present to us fibromyalgia syndrome, and he will not present the usual fibromyalgia. I think he has something in mind on the other face of fibromyalgia. So let us play the mask game.
شكرا.
تفضل.
شكرا جزيلا. Fibromyalgia syndrome is a very painful presentation to do. It took a long time to try to put everything in text, so I can tell you something. Most of you know it, but I will add also something I can experienced already from the longer-term working here in Egypt and in different countries, and lately for the last 25 years in the UK. When I arrived to the UK in the 1996, I did some studies for 2 years as a postgraduate full-time student. But when I started to work officially in 1998, and I faced with this tsunami of fibromyalgia syndrome, which at that time I didn't used to see most of the fibromyalgia syndrome in Egypt. And I still remember one of the questions asked by one of my colleague, and how much is the percentage of fibromyalgia syndrome in Egypt? And for sure at that time I don't have any clue what to say, but I have said, in Egypt we don't have time for fibromyalgia. So I think I don't know whether it's still valid answer or not, but I wish I could hear from you as a people dealing with the current situation, how much fibromyalgia in Egypt now. So it has remained a condition whose pathogenesis is not entirely understood, affecting significant proportion of global population, and it affects life quality, and is still considered medically benign up to this moment. It does not cause any heart attack, stroke, cancer, or physical deformities of loss of life, but it is still affecting the quality of life. So this question has been asked when I was a medical student in Ain Shams University: what is the role of physicians in medicine? And I still remember that the answer was unknown by any of the attendants, but the professor told us the role of physician is to restore function. A bit of history about fibromyalgia. In 1980s, it was not known fibromyalgia at all, but chronic fatigue syndrome at the time thought to be central nervous system exhaustion resulting from modern civilization. In 1990s, they start to say this chronic fatigue syndrome can be neuroathenia. And at the time they related to polio and the polio vaccine, and they call it ME, and still people up to this moment call chronic fatigue syndrome as an ME, and they consider it as a psychological phenomena. After that, in 1987, the fibromyalgia started to appear to the surface as a chronic widespread syndrome affecting muscles, joints, and everywhere. So it is the most common cause of widespread musculoskeletal pain. Comes with fatigue, cognitive disturbance, psychological symptoms, multiple somatic symptoms. I will come to this one in a minute. But despite of symptoms of soft tissue pain affecting muscle, ligament, tendons, there is no evidence, or there is no clear evidence, put the word clear here, of inflammation of this tissue, because I will come to this one in a minute. So this is the prevalence of widespread syndrome and where is fibromyalgia is. So not every widespread pain is fibromyalgia. This is very important from this thing. So what causes fibromyalgia? This is the question of 1 million sterling pound, not dollar. It is unclear, but it may be different from different patients. Different people, different cities, different subcontinent, different backgrounds, different educations, different heritage, different everything, different education, different financial situation. So it differs from one patient to another. Current research suggests that the involvement of the central nervous system, and it is probably not from an autoimmune inflammatory joint or muscular disorders. Family history is important, but it is not must. Sometimes we hear from our patients that my mom, my mother, or my aunt, or my father has fibromyalgia. So, but it is not something we can rely on. So gene therapy is playing a major role, yes, and this is the family tendency may be related to the home circumstances. For example, in the UK, for example, if we have a chronic alcoholic father, most probably the rest of his children will develop fibromyalgia in certain stage of their life. I still remember one of the patients told me that my mother used to close our doors when my father came back home drunk. Fibromyalgia is, as a result of it, changes in the body talks with the spinal cord and the brain. Level of brain chemicals and the protein may change. More recently, fibromyalgia has been described as a central pain amplification disorder, meaning that the volume of pain sensation in the brain is turned up too high. So there, for pain, there is like a thermostat. Something will make the pain up and down. And in World War II, they started to recognize that some soldiers come to the doctor's tent carrying their own chopped arms. So as major trauma, and he's walking with his arm in his hand, chopped, this completely amputated out of his body. And they came to the doctor's tent without any pain. So when you see the rugby player, the people who playing rugby, the amount of knocking down between all of them is tremendous, but they don't feel any pain. The same for the karate player, which is my hobby to do. Most of the patients invariably experience abuse or neglect as a childhood has been linked to lifelong ill health and fibromyalgia. One of the scientists I met in 2005 in Berlin, he said that invariably, there is some event in the life of the patient of fibromyalgia, which is stored in the back memory and they still regurgitate in the recent memory all the time. So fibromyalgia has no age group. It can be in the children and for everybody dealing with that, and for our children as well, we need to recognize that it is a widespread muscle pain in 91% of the children who develop fibromyalgia. Frequent headaches, non-restorative sleep, we call it unrefreshing sleep. Unrefreshing sleep does not mean that they don't sleep less or more. Some people can sleep 12 hours and they still can come up in the morning very unrefreshed. And you know that the normal healthy sleep is to recharge two batteries, physical and emotional batteries. If you don't recharge your batteries, it will be drained. Hypermobility on examination, sensitive tissue swelling of the extremities, irritable bowel syndrome, and hypersomnia. Some people, they don't sleep well at all, at the number of hours. The pathogenesis of fibromyalgia may complicate many rheumatological diseases. We call it secondary fibromyalgia, or can be primary. I'm going to focus today about primary fibromyalgia, and I will mention one or two examples of secondary fibromyalgia. I noticed also that some people find it very easy to label patients with musculoskeletal pain as fibromyalgia, and they miss a very important underlying rheumatological problem. So ongoing research is focusing on the small fiber neuropathy. Some studies have documented it is associated with central sensitization. In contrast, others have revealed distinct sensory profile in patients with fibromyalgia and the small fiber neuropathy compared to those with a small fiber neuropathy. From this slide, I would like just to highlight not all small fiber neuropathy can be presented with fibromyalgia. There is a distinct pathway. What it is still unknown. So if you sit in any chair, for example, in this one on the this one here, with bended back for a short period of time, there will no any pain and you will keep going. But after a long time, central sensitization will start to send some signals to the brain, especially the dorsum ganglion, and then the brain will cause pain in the lower part of the back. Then you will sit straight to alleviate the pain. And the diseases associated with central sensitivity syndrome, as you can see, is a lot. And some of them are presented in the same time, like, for example, restless leg syndrome, post-traumatic stress disorder as a precipitating factor. Post-traumatic stress disorder is very important, like if you have a bereavement, like someone who missed the beloved member of the family, like mother, father, anyone related relative, motor car accident, major disasters, any major trauma can have what's called the post-traumatic stress disorder. Myofascial pain syndrome, pelvic pain syndrome, ME or coronary fatigue syndrome, irritable larynx syndrome, sensitivity, chronic Lyme disease, irritable bowel syndrome, and irritable bladder syndrome as well, The people get up at night many times to go to the loo without any explanation. They are not diabetic, they are not hypertensive, they are not elderly male with chronic benign prostate. They don't have any organic organs to make them have a inverted D over N micturition habit. Bot's disease. Bot's disease is very common among the young ladies with the or young boys with the with hypermobility syndrome, postural orthostatic tachycardia syndrome, temporal mandibular disorder, tension headache, and this is the trigger factors. I put it in this slide for reference: poor sleep, physical trauma, infection, other factors, autoimmune nervous system, psychological disorder, neonatal trauma, environmental changes, and this all can end up with central pain syndrome. This is the role of the dorsal ganglia, and dorsal root ganglia play a crucial role in the pathogenesis of fibromyalgia as the host satellite ganglions, which are targeted by the brain-driving immunoglobulin G. Immunoglobulin G have been identified in a subset of patients exhibiting high symptoms and severity. There is also a critical study conducted on animal, and the animal models confirmed the role of neuroinflammation at the level of the dorsal root ganglia. In this case, is mediated by polymorphonuclear neutrophils. And here I need to just highlight that you don't get surprised in the future if someone ends up by telling you that fibromyalgia discovered to be an inflammatory rheumatological problem, and then will give the patient some methotrexate or even biologic medicine. So the future is still holding a lot of things. The number of fibromyalgia patients in the world is extensive. Me, myself, at the clinic before I came here, the previous one, out of 6 new patients, I got 3 fibromyalgia. So it is not, it is a good cohort of patients, and this will lubricate the saliva of the drug company to put some money on the researchers to end up by having some medication for it. Also post-COVID syndrome, COVID-19, we noticed, is just an observation, that a lot of people after COVID infection start to develop fibromyalgia. And they are trying now to identify some biomarkers for fibromyalgia diagnosis. Something like rheumatoid factor and NCCP for rheumatoid arthritis. They are trying to do something for COVID as well. So it is inflammation, autoimmune, and infection in fibromyalgia is a narrative reviews. The pain of fibromyalgia has been classified as a nociplastic pain. And this nociplastic pain is unique. And they can be mistaken with the musculoskeletal one, can be mistaken with the neuropathic pain, and they can be mistaken with psychosomatic pain. This is from scientific point of view, but in reality, it is extremely difficult to distinguish between all of them. Especially when you are dealing with, I don't want to say non-educated people, I say lay people or common people. It's so difficult. So this is the character of nociplastic pain. spontaneous sudden onset, inconsistent with underlying pain, pain more than 6 weeks or more than 3 months in certain topics, history of fail of treatment. The patient will tell you, I went to many doctors, but none of them did help me. Disturbing sleep, this is very important. Don't ask about the number of hours of sleep, but also ask for whether it is a refreshing or unrefreshing sleep. More constant or unremitting, widespread diffuse pain. It's not usually responding to non-steroidal anti-inflammatory. It can be responded, but in early stage. Even some people, when they go to any doctor, give them a course of steroid for 1 or 2 weeks, they may feel initial improvement, but after that they don't get any benefit out of steroids. It can be associated also with other unpleasant sensation like burning sensation, coldness, and crawling. You know, crawling, the people tended to crawl. It is very bad when you see a crawling patient. Some patient comes walking and other patient comes to the clinic on a wheelchair. Causes of widespread pain is huge, so we need to be aware about all of them. And this is in England, they have a say that there is a right way and wrong way and my own way. I'm going to tell you now about my own way. So it is not right or not wrong. I can see fibromyalgia is a body reaction to something I'm not involving directly with. So it's not a disease in my body, but I am reacting to something might be in the past, might be 20, 30 years before, might be just yesterday. And my analogy is, if you have a beloved child crossing the street and a car coming from the other side and you are in the 5th floor, watching the scenery in the front of you that the car is going to hit the child, what you are going to feel? You're going to start agitated, increasing heart rate, sweaty, anxious. You need to shout, but you couldn't because nobody will hear you. So you have a physical changes in your own body, which is real to something outside your body. To me, this is what is fibromyalgia is. And this is normal for everyone, and they shouldn't be diagnosed as fibromyalgia. But if these symptoms they stay for 1 or 2, 3, 4 weeks or months or a year, you still remember the scene, I still remember reacting to at that time, it is fibromyalgia. So fibromyalgia to me is an exaggeration of the normal reaction we have in our social life. And this is a tender point. I no longer use these tender points. I have a big thumb to put, they're telling us how to put the thumb on the targeted point and to put 4-pound pressure on it. 4-pound pressure from my thumb is different from 4-pound pressure of your thumb. And when you see real fibromyalgia, they will ouch anywhere, not only on the 18 points. So what I'm doing, I'm giving them the booklet of fibromyalgia for patient information and give it to them. Please have 5-10 minutes outside, read it, and I circle 2 boxes for them. If you found yourself in one of these boxes, tick it. And most of them can tick that yes. Sometimes we have a patient for rheumatoid arthritis doing very well on methotrexate or biologic or sulfasalazine or whatever. Then the patient come back to you telling you, my pain is tremendous now. I've been doing very well for the last 3-4 years. Now I have a pain on all my joints, and I feel that the medication is no longer doing any good. And they come with a great mood disturbance, greater sleep disturbance, neuropathic symptoms, and often this rheumatoid arthritis people are seronegative. And when you measure the inflammation markers and the acute phase proteins, it will come within normal. So at that time, think about fibromyalgia associated with the rheumatoid arthritis as a secondary fibromyalgia. Differential diagnosis, fibromyalgia is in a gray area of all of our rheumatological spectrum, like lupus, rheumatoid, BMR, myositis, hypothyroidism, hyperparathyroidism, and hypoparathyroidism as well, and the neuropathies. So we all know how to differentiate clinically with. The problem here that I'll come to this one in a minute, that you don't have to investigate the patient in the front of you if you feel that this is the fibromyalgia. So we said this picture before. And here HBAG or hypothalamus, pituitary, adrenal gland, these are the 4 organs give the symptoms of fibromyalgia. And we already went through all of that, but I put it in a different context where these symptoms comes from. So the criteria needed for the diagnosis, and remember the criteria is not for clinical diagnosis, the criteria is for research. When you do research, you need some criteria to have ins and outs to recruit patients for fibromyalgia for a study or not. But anyway, it is fatigue, walking unrefreshed, cognitive function, like memory loss. Memory loss is very important to fibromyalgia. Recent memory loss. You go to one room and you don't know where are you going and what is the reason for that. We have all these things. Yeah, I can see some people laughing here. Yes, we all have these things. We don't remember. And when someone told you call your children, come and I will tell you something. And when they come, oh, I forgot what to tell you. No, it's not that. It is more than that. When you see a patient with brain fogs, they call it in England brain fogs. Foggy brain, foggy like fogs, the bulb. You will know that you are healthy. Don't worry about that. The symptoms for more than 3 months. So history of early cost-effective diagnosis. This is one of the best slides in my talk. By the way, I will leave this presentation for anyone to have because there is few things in Arabic I will come to. So it's chronic widespread pain, more than 3 months, absence of other systemic condition. I'm hurting all over. I feel like I'm always having a flu-like symptoms, fatigue, sleep, mood disturbance, irritable bladder, irritable bowel, somatic complaint. And you don't have to screen all the autoimmune profile. The reason why I'm telling that, for example, if you have a pure fibromyalgia and you screen the ANA, for example, then you will end up by having a positive ANA. What you are going to do? You are in dilemma now. You need to do C3 and C4 to see what is significant or significant. C4 is low. What is that significant? You need to do another test to see is this patient has hypocomplementemia or not. You will end up by just going from one test to another and wasting your time and the patient's money. Management of fibromyalgia, here we are. The best thing to do for fibromyalgia is education. Education. not only for the patient and for every member of the family. You need to meet the patient, and you need to have the permission of the patient to see the other family members, because they need to live with the patient with fibromyalgia. It's not easy to live with the patient for fibromyalgia. And it is a cause of divorce. Fibromyalgia is a cause of divorce, because whether the man or the lady have fibromyalgia, they can cope with the other partner or other half. So this is some Arabic things I managed to have. So if you need to take a copy now, if you need, I'll leave the presentation for all of you to have. This is very important for teaching, and every line of this needs to be explained to the patient. This is the management in the very crowded, unpleasant slide. Don't worry about that, but I made it in a nice way. So exercise, talking therapy, and finally medicine. Exercise, talking, and the medicine. 3 elements of how to manage fibromyalgia. Exercising is very important and very crucial, because if you tell the patient you need to exercise, first of things they will go and walk for 1 hour or jumping or going to the gym, then the pain will come more severe, then you will stop exercising. So what you need to do is to tell the patient that you need to upgrade your exercise, upgrade it gradually. Even if they can start by 10-15 minutes, then build it up after 2 weeks or 4 weeks. And the best thing is aerobic exercise, which aerobic means that something to increase the heart rate and make you a little bit sweaty. Finally, they found that also gym exercising is second best. Gym, if you go to the gym with some machines, it's very good as well. So non-drug treatment focus in non-drug initiality aerobic exercise. I said cognitive behavior, CBT, cognitive behavior therapy. It is very important to educate your patients that they need some help in how to live with fibromyalgia. You need to reassure the patients that you are not crazy, you are not mad, you don't have any psychological problem, you don't have a disease to get ashamed with, so they will accept your advice. Cognitive behavioral therapy is so important, and also ACT, acceptance therapy as well, is very important. Counseling, I'll come to this. Acupuncture is important as well. We said that. Talking therapy, again, I'll come again to the talking therapy. Acceptance and the commitment therapy, ACT, الرضا والالتزام. It is crucially important to live in harmony with your past and have a tranquility about your future, to enjoy your day. السلوك المعرفي, العلاج cognitive therapy, and you don't have to do it yourself. Just ask one of your psychiatrists or psychologists to do it for you. Counseling is very important, someone to talk to. And the least people who got fibromyalgia syndrome are the farmers. And if anybody has a farmer background like me, my grandfather, all of them are farmers, and I used to live with them when I was a child. They have what's called the mastaba. Do you know mastaba? Good, very good. We all know mastaba. They sit in the mastaba after Asr prayer or after Maghrib prayer, and they drink some tea and they chat. Talking. They talk about what? Anything and everything. When you talk about something, you are going to talk about 2 things. For example, now I am talking about fibromyalgia. This is one, and at the same time I'm talking about myself. Anyone, not me, anyone, when they start to talk, you are going to talk about 2 things. The subjects you are involved to, and your own personality. And you might hear something is not in the context of the subject of the talk. If we are talking about Ahli and Zamalek, he will tell you, but my wife yesterday told me off. So you don't know what is about your wife here in Ahli and Zamalek. You don't care about that. He just have something he needs to spit it out. And this is so important. In America, they have what's called a mass talking. They bring all the people of Fiber Maza, put them in the club near the sea with some coffee and tea and drinks, and they let them talk. So non-drug therapy, we said all about that. This is a nice way to put it in, a non-pharmacological intervention. Yes. And should be individual. Different people are different. Medication, the last thing in the line. The last thing in the line of the management of fibromyalgia is the medication. Amitriptyline comes first, duloxetine, melanocipran, or cyclozapine, or pregabalin, or gabapentin, whatever suits the patient, you can put them on. And the warn is a patient. Warn is a patient that medication is not it's not a radical solution. Some of the medication are good, some are not. Tramadol is not good for in Egypt, but tramadol is a normal medication like paracetamol in the UK. I don't know what is the difference. Like anything in medicine, in new medicine, the Western try to turn the disease activity to numbers, like DAS28, like for ankylosing spondylitis, what's called, like anything, to turn the disease activity to numbers, something called kilometrics. And this kilometrics is the most recent thing. Is they are working now on fibromyalgia to turn the disease activity to number. That's why when you treat the patient, take care of the number. So you know what T to T is. Treat to target. So you will have a target to treat for. Prognosis is different from one patient to another. Mortality and suicidality. Some people, because in England, can take their own life or nearby, but the amount, the essence of this slide, that it is not a big deal. Fibromyalgia is not different from any other diseases. At the role of rheumatologist, however, because fibromyalgia can cause chronic pain, fatigue, arthritis, some people advise to see a rheumatologist. As a result, often rheumatologists detect this disease, and they found that extensive home care is better than tertiary referral center. شكرا جزيلا. This is fast fact or home take message. 2 to 4% of people, women than men, more than men. Fibromyalgia is not an autoimmune disease, and they use the booklet. There is a version of this booklet in Arabic. You can give it to the patient to read, and they diagnose themselves. There is no test for fibromyalgia up to now. There is no cure, radical cure. There is cure, but not radical. Patient also may feel better with proper self-care, such as exercise and getting enough sleep. Remember, the word did change. Tell the patient to change anything, it could be changed. And here, all of us know what Dr. Ali. Dr. Ali is coming tomorrow. And when he asked me what are you going to say to us, I told him fibromyalgia, and he said this is the بكاء الروح وأنين الجسد الصامت. And here we are, Omar Khayyam. Everybody knows Omar Khayyam. لا تشغل البال بماضي الزمان ولا بآية العيش قبل الأوان، واغنم من الحاضر لذاته فليس في طبع الليالي الأمان. غد بظهر الغيب واليوم لي، وكم يخيب الظن في المقبل، ولست بالغافل حتى أرى جمال دنياي ولا أجتلي. Here we are, مسك الختام، لكي لا تأسوا على ما فاتكم ولا تفرحوا بما آتاكم، والله لا يحب كل مختال فخور. شكرا.
شكرا دكتور. Very nice presentation, but we are short of time, so we'll have to move to the next speaker because she's waiting online. Professor Appenzeller. Okay. Hi, Dr. Simone Appenzeller. Are you? Sorry for keeping you waiting for a few minutes more, but you can take all the time you need.
Hello? Yep. Yeah, now I'm with it.
Okay, we are ready now. Professor Simone Appenzeller is a full professor of rheumatology, School of Medical Science, University of Campinas, MD and PhD at University of Campinas, Brazil, postdoctoral fellow at McGill University in Canada, and Stavanger University. She's member of the Brazilian Society of Rheumatology, PANLAR, CARA, and ACR with different leadership and committee roles. In the ACR, Dr. Appenzeller is an international advisor in the Global Engagement Committee, and I have the honor of being her colleague in this group. She's also member of editorial board of Autoimmunity Reviews, the journal, and the Lupus Scientific Reports, among others. Dr. Appenzeller asked me, what would you like me to talk about in lupus? And she suggests, just mentioned a hint on nephritis. I said, lupus nephritis is always en vogue, or always fashionable. It doesn't lose its sheen. So Dr. Simone Appenzeller will talk to us today on lupus nephritis updates. Will you please proceed? And thank you for accepting our invitation. We are honored to have you with us.
I would like to thank the kind invitation from the Egyptian Society of Clinical Immunology and Rheumatology in your name. And it's an honor to present here. I'm just going to share my screen to see if it's working. 1 second. It wasn't showing adequately, so it's an honor to be part of this meeting today, and I'm going to speak about the update in lupus nephritis. These are my disclosures, but all of them had been mitigated for this talk. I'm going to speak a little bit about the diagnosis of lupus nephritis, the role of kidney biopsy for lupus nephritis diagnosis and prognosis, the role of repeated kidney biopsy, diagnostic and prognostic biomarkers, and treatment. So as we know, environmental and epigenetic factors are important to cause the loss of tolerance to self-antigen, development of autoantibodies that lead to tissue and organ damage in SLE. In addition, the genetic, environmental, immunoregulatory, hormonal, and epigenetic factors influence immune complex formation, antibody production, cytokine production, and T-cell actions that lead to organ damage in SLE. Lupus nephritis is an important clinical manifestation. It occurs in up to 50% of lupus patients in most of the study in the first 3 years of disease. An additional important aspect is that about 30% may end on end-stage renal disease, and 10% it's already in the first 5 years of disease, reaching 30% at 15 years of disease duration. So lupus nephritis is associated with a 7 to 30% risk of kidney failure, a 19 times higher overall mortality, reduced quality of life, and has an important economic impact factor for patients. Considering the treat to target that was previously mentioned in fibromyalgia, so we also have it in lupus, we should consider that treatment should target always remission in the lowest possible disease activity, measured by a validated lupus activity index and or by organ-specific markers. And in specific case of lupus nephritis, the early recognition and treatment of renal involvement is strongly recommended. So how can we do the early recognition? This is the new KDIGO clinical practice guideline that was recently published, and they recommend that in SLE patients that have disease that are early diagnosed or during follow-up, we should do in the routine analysis serum creatinine, urine analysis that could be dipstick or sediment, spot protein creatine ratio, and serology such as anti-DNA and complement. If they are abnormal, we should always consider non-lupus related factors and treat them. If we think that they are lupus related, they recommend quantified proteinuria and a 24-hour proteinuria. And if that's abnormal, consider kidney biopsy. Should we do spot protein creatine ratio or 24-hour proteinuria? So that's always a question. And when we look at the studies, there is a strong correlation between both studies. However, there is a high heterogeneity. But most authors agree that spot protein creatine ratio is a good for screening and follow-up. But an important factor to consider is that low-grade proteinuria does not exclude significant kidney injury in patients with lupus. So in this study, they included only patients with proteinuria less than 0.25. They had patients with normal creatine function and patients with lower creatine function. However, all patients had glomerular hematuria. What they observed is that there was a significant frequency of class 3 and class 24% in patients with low protein, with proteinuria less than 0.25, however, with the presence of glomerular hematuria. So they concluded that this was a very early lupus nephritis cohort, that most of the patients had disease activity for 2 to 5 months. And they also already had significant activity and chronicity. In addition, when they compared patients with proteinuria over 0.5 and under 0.5, they observed that 70% of the patients with proteinuria under 0.5 also had class 3 and class 4 nephritis. So it's important to screen not only for proteinuria, but also with urine analysis for glomerular hematuria. It's important to remember that this is not a silent lupus nephritis, because silent lupus nephritis is defined if there is no urinary abnormality, so there is no glomerular hematuria, and proteinuria is less than 0.3. In silent lupus nephritis, around 70% are class 1 and class 2, and only 20% are class 3 and class 4. So the gold standard, if we have urine abnormality and quantified proteinuria, is renal biopsy. What do we expect on the renal biopsy? We can find a class 1 that would be a minimal mesangial expansion. We can have a class 2 where on hematoxylin eosinophil staining and GMS staining we observe a mesangial hypercellularity. We can observe a class 3 that's a focal lupus nephritis where we have a segmental endocapillary proliferation noted in less than 50% of all glomeruli. A diffuse lupus nephritis that is class 4 where we have on PAS endocapillary mesangial hypercellularity, cellular crescent, on GMS staining, subendothelial hyaline deposit, and on MT staining, fibrinoid necrosis, and the membranoproliferative pattern on class 5. Class 6 is already at advanced sclerosis, where we have sclerosis in more than 90% of the glomeruli, on hematoxylin eosin staining or metanim staining without signs of disease activity. One of the difficulties that we often observe around the world is that the biopsy has to be seen by an experienced kidney pathologist. So they have to analyze disease activity index, chronicity index, and score them. Activity index is analyzed by endocapillary hypercellularity, neutrophils and chirorrhexis, fibrinoid necrosis, presence of fibrocellular crescent, and interstitial inflammation, and the chronicity index by glomerulosclerosis, fibrous crescent, interstitial fibrosis, and tubular atrophy. All these are scored according to the extent observed in the glomeruli, and the 3 points would be present in more than 50% of the glomeruli. The activity index ranges from 0 to 24, and the chronicity index from 0 to 12. It's important to realize that podocytopathy, collapsing lupus glomerulopathy, and vascular lesions are not included in the current scores. Should we do only one biopsy, or should we repeat biopsy? So, we don't have, we normally, it's difficult to get repeated biopsy, but in this study, they did biopsy at study entry, after induction therapy, the second biopsy, and the third biopsy was done in a median of 42 months after disease onset. What did they observe? That 1/3 of the patients still had histological activity present at the third biopsy, and they maintained immunosuppression until there was no histological activity. What did they observe? In red, we have the patients that had no histological activity at the third biopsy, and in blue, patients that had histological activity at the third biopsy. They observed that there was a biphasic reduction in activity index. Highly inflammatory lesion as neutrophil, chirorrhexis, fibrinoid necrosis, fibrocellular crescent resolved completely during initial immunosuppressive treatment in both groups, showing that standard of treatment works well for highly inflammatory lesion. However, 81% maintained disease activity at the second biopsy, despite receiving immunosuppression. And endocapillary hypercellularity, subendothelial hyaline deposits, and interstitial inflammation seem to be more resistant to standard of care therapy. And they were still present in 50 or 60% of patients after 8 to 9 months of treatment. However, they resolve in many patients during long-term follow-up. So glomerular endocapillary hypercellularity and subendothelial hyaline deposit drive persistent histological activity in individuals who still have histological activity at biopsy free. So that's why we should keep immunosuppression for a long period of time. Another interesting finding that they observed is that the chronicity index is also biphasic, and there was no difference regarding patients that entered remission, histological remission, at the third biopsy compared to patients that did not enter remission. In addition, the chronicity, the renal damage, occurred very early during the course of the disease, between the first and the second biopsy. Suggesting that we still have to work harder to reduce the renal damage in our patients. However, we know that in clinical practice, renal biopsy is not always feasible. Sometimes we have contraindications, sometimes renal biopsy might delay initial treatment. So biomarkers have emerged as a possible link to close between the histological findings and an early diagnosis. To have an adequate biomarker, this biomarker needs to be specific, easy to perform, and cost-effective. And we have different kinds of biomarkers. So we should have a diagnostic biomarker to allow us to have an early diagnosis of nephritis, a prognostic biomarker that would independently of disease treatment show us the patients that have a good or a bad prognosis, and predictive biomarkers which should show us the response to treatment. Just reminding that sensitivity and specificity are independent of the population. However, when we look at positive predictor value and negative predictor value, they depend on the prevalence of the disease in the population. And another aspect that we should consider when we look at biomarkers is the area under the curve. And the higher the area under the curve, the better classification. So we should see here in blue, it's a better classification than the one in yellow. So what do we know about our traditional diagnostic biomarkers of lupus nephritis? They are not good biomarkers for diagnostic, prognosis, or to show us the response to treatment, because they have a variable sensitivity and a low area under the curve. Specifically, if we look at complement C3 and C4 and double-stranded DNA, both 2 to 3 months prior to nephritis, as at a nephritis diagnosis, they have a below positive predictive value, and once corrected for extrarenal disease activity, they no longer significantly predict renal flares. So I have listed here at the right different urinary biomarkers that have been studied in more than one study in SLE and compared patients with and without nephritis as control. All the studies have included renal biopsy as gold standard, and the urine biomarkers have been used for diagnosis, prognosis, and response to treatment. Why do we have so many different biomarkers? Because these biomarkers, they have different functions and they are located in different areas of the kidney. And if we look at our disease activity score and chronicity score, we see that there are different areas involved. So we can have the involvement of Bowman capsule, glomeruli, tubuli, or endothelial cell, and the interstitial space. So that's why normally we have different biomarkers in that relate to disease activity and chronicity. In a proteomic study that did in 30 patients as the EGYSIR study, they identified IL-16, TGF-beta1, and CD163 as the major biomarkers related to disease activity. They were not related to chronicity, and they had a medium correlation with proteinuria, showing that proteinuria, as we know in clinical practice, is not a good biomarker for disease activity, because if we have renal damage, we still have persistent proteinuria, residual proteinuria. They also showed that IL-16 is the major cytokine in the kidney, and that IL-16 is shown in all cells that involved in lupus nephritis in the different areas of the kidney. On the other hand, CD163 has been only identified in macrophage and TGF-beta1 only in natural killer cells. They have done a validation cohort, a follow-up validation cohort, that they enrolled 225 patients from diverse ethnic background, but all from the United States, that had initial biopsy and urine analysis at week 0, 12, 24, and 52. These patients didn't have a follow-up biopsy. They still realized that IL-16 and CD163 was the major biomarkers for disease activity for diagnostic of lupus nephritis, And they showed that this is especially for patients with membranoproliferative nephritis. And this shows that there are different aspects involved in lupus nephritis. So we have macrophage activation, we have cytokine, and we have wound healing. On the other hand, there are different cytokines, different biomarkers involved in chronicity, especially leptin and cysteine SN, and cellular 1, which are the major factors associated with chronicity as biomarkers. Furthermore, they did a follow-up study and looked at patients that responded at 3 months and at 52 months. And they showed that the reduction of galectin-1 and CD163 were the major players in disease activity, so the reduction of both of them associated with response. They compared CD163 and CD206, that was a major respondent for proliferative nephritis in this area under the curve, where in blue we have proteinuria, and in red we have CD163, and then over here in a darker red, the CD206, showing that they have a good area under the curve. In addition, they've shown here in the graph on the bottom, in blue we have the complete responders, in green the partial responders, and in red the non-responders. That these biomarkers were able to differentiate between complete responders and non-responders. However, they were only done in the United States, and there are necessity to validate in other ethnic backgrounds. There are other biomarkers that have been established. So these are mostly biomarker panels, including more than one biomarker. So this was in the UK study in pediatric lupus nephritis, where they included 6 different urinary biomarkers, and they showed that these biomarkers had an area under the curve of 0.9 compared and much better than compared to traditional biomarkers. And they validated this cohort in a second cohort, also showing a good validation cohort, but it has also not been studied in different ethnic backgrounds. The renal activity index for lupus nephritis, that's the RAIL score, also includes 6 different biomarkers that are related to different areas in the kidney. So we have the NGAL that is found in the distal and proximal nephron, MCP that's shown in the renal epithelium cell, KI1 that is shown in the proximal nephron, adiponectin that is shown to suppress inflammation, hemopexin that's in the proximal nephron, for example. The RAIL study has also been shown to be a biomarker for active lupus nephritis lesion, both in adults as well in pediatrics. They are also done in the urine. In addition, they have been shown to forecast remission with an area under the curve of over 90%. So here they show that they can differentiate between disease activity, high disease activity, medium disease activity, and low disease activity, and between complete responders and partial responders. In addition, the RAIL score is not influenced by treatment, so it can be used as a prognostic biomarker in lupus nephritis. When we look at the best renal outcomes, studies have shown that we should aim at a proteinuria of less than 0.8 grams in 12 months. So when we do follow up the patients for treatment, we should try to observe a reduction in 25% at 3 months, reduction at 50% at 6 months, aiming at less than 0.8 grams at 12 months. Over the decades, significant new targets and treatment has been studied and approved for lupus nephritis. So we started in the 70s only with cyclophosphamide. Afterwards, that acts on T cells. Then we have the mycophenolate, azathioprine, the calcium cyclosporine and tacrolimus that are calcium inhibitors. And we, over the years, have now belimumab, obtinuzumab, voclosporin, and other treatments. And more recently, anti-CD19 CAR T cell have been studied in lupus. However, there are still no phase 3 trial results. What do we have as the new treatment option for lupus nephritis? So we have belimumab that has been shown in a phase 3 BLISS trial, showing that there was a significant higher complete renal response in patients using belimumab when compared to standard of care. Belimumab was added on to mycophenolate or to cyclophosphamide. However, in an ad hoc analysis, it has been shown that patients with nephrotic proteinuria have a lower response than patients with lower proteinuria, suggesting that belimumab might be lost in the urine in patients with nephrotic proteinuria. Another aspect that we should consider is that belimumab is not indicated in patients with depression because it might induce suicide risk. However, there were no significant data in the trial, and these patients were excluded from the trial. Voclosporin has appeared in 2 trials, a short-term and a long-term, 3 years study, showing also that there's a significant reduction, significant higher proportion of patients reaching clinical remission when compared to standard of care. Voclosporin has a side effect to induce hypertension and a rapid rise in serum creatinine in some patients. However, compared to cyclosporine and tacrolimus, it has a lesser risk of dyslipidemia and diabetes too. Voclosporin has been shown to rapidly reduce proteinuria, so it's indicated in patients with nephrotic syndrome that have normal glomerular function. Anafrilumab, on the other side, had similar proteinuria reduction in the arms with patients with anafrilumab and in the control group. So this is the algorithm from the Brazilian Society of Rheumatology that was recently published, and I will guide you through it. So one important aspect when we consider in treatment of patients with lupus nephritis is the adjuvant therapy. So we should not forget to give hydroxychloroquine at 5 milligram kilo day of real body weight with a maximum of 400 milligram day. We should aim as an adequate blood pressure control and cholesterol control to reduce cardiovascular risk factors. We should aim at vaccination and adequate contraception because these patients should not get pregnant during lupus nephritis induction. So the ideal is to have at least 6 months of remission before getting. So we recommend that in proliferative lupus nephritis, the induction can be done with mycophenolate mofetil 2 to 3 grams a day for 6 months, and or cyclophosphamide. We prefer to use the Eurolupus to reduce infertility. However, we know that not all centers are able to have patients to have cyclophosphamide every 15 days. So we still recommend the NIH cyclophosphamide trial with 0.5 to 1 gram monthly for 6 months. We live in a big country. Sometimes patients don't have the ability to come every 15 days as well. If there is no, if the target renal response is not achieved at 3 to 6 months, the induction treatment should be changed. You can change mycophenolate to cyclophosphamide or cyclophosphamide to mycophenolate, or you can add on tacrolimus to mycophenolate or belimumab to mycophenolate. We did not include in this guideline voclosporin because it was not approved yet by our national health government policies. Maintenance therapy should be aimed to 3 to 5 years to reduce flares, and this could be done with mycophenolate or azathioprine. We also gave the option of tacrolimus, cyclosporin, or leflunomide for maintenance therapy over time. In patients with refractory lupus nephritis, we recommend, and if an adequate adherence treatment, rituximab could be an option. On the other hand, in patients with membranous nephritis, the adjuvant therapy is the same, and we can use mycophenolate, cyclophosphamide, azathioprine, or multi-target mycophenolate and tacrolimus, or only tacrolimus, or cyclosporin for induction therapy. If there is the target renal response is not achieved, there should be a change between these treatments. In cases of refractory cases, we can use rituximab. And the maintenance therapy is also 3 to 5 years with mycophenolate, azathioprine, or mycophenolate and tacrolimus. This is the EGYSIR Lupus Clinic algorithm from the US, and they have a similar algorithm. One aspect that I forgot to emphasize is that when we do the induction therapy with methylprednisolone, we should aim at lower dose of prednisone. So in our guideline, in the Brazilian guideline, we recommend the induction methylprednisolone up to 500 milligram a day for 1 to 3 days, maintaining oral prednisone from 0.25 to 0.5 milligrams kilo a day, and aiming to taper up to less than 5 milligrams a day in 3 to 6 months. This aspect is also emphasized in the US guidelines. So we should really aim to reduce total corticosteroid dose to have less corticosteroid toxicity. They also do the induction therapy with cyclophosphamide or mycophenolate. If there is no response, they switch between both. If there is a partial response, there is the option of add-on belimumab or voclosporin, depending on the degree of proteinuria and the glomerular function rate, and a long-term 3 to 5 year maintenance therapy. What should be taken into consideration when we choose immunosuppressants? So we should determine adherence, easy access, need of infusion center, refractory case, if the patient wants to get pregnant or not, compatibility with lactation, risk of infertility, high cost, and I would add now with voclosporin, glomerular function rate, and the degree of proteinuria. So we know that IV infusions have a favor adherence. Access is better for medication that we have freely available in Brazil. The costs are higher for belimumab, rituximab than for cyclophosphamide or mycophenolate, for instance. Another question that have arisen is that if we should do rituximab after belimumab. So in this trial, they compared belimumab followed by placebo with patients using 144 patients using belimumab followed by rituximab, and 76 patients with belimumab followed by standard of care. The primary endpoint was negative, so the disease control at week 52 was similar in the three groups, as the same observed for the major secondary outcomes, which there was no difference between the three groups. This does not mean that it's not indicated to use rituximab after belimumab. Is that in this study there was no major difference between the three groups. In this systematic review with network meta-analysis, including around 2,000 patients, the authors showed that there is a superior efficacy in the treatment for lupus nephritis with multi-target therapy, obinutuzumab, belimumab, and voclosporin. However, a multi-target therapy, most of the study have only included patients with Asian descendants. They have also shown in a cluster analysis, when considered safety and efficacy of obinutuzumab and belimumab had a better safety and efficacy effect. What about SGLT2 inhibitors? Dapagliflozin has been studied in a phase 1 and 2 trial. Phase 3 trial is still underway. And they have shown in this phase 1, phase 2 trial that patients using dapagliflozin had an overall better survival, less heart failure, and less mortality, and developed less frequently a chronic renal disease. So my take-home message is that renal biopsy and now urinary biomarkers have improved diagnosis and prognosis. They can also they are being studied to be used also as a response to treatment. However, urinary biomarkers are still expensive and not available throughout the world. We should always aim at histological remission, especially if we have adequate biomarkers for it, because clinical remission is not equivalent to histological remission. Renal damage occurs early in the course of lupus nephritis, and we should really aim to reduce the frequency of it. And now we should treat early with less corticosteroid dose and consider add-on therapy with belimumab and voclosporin or tacrolimus in multi-target in patients with partial response. I would like to thank again for the kind invitation, and I'm happy to take any question if there's still time.
Thank you very much, Professor Akinzela. I think we can take just one question and move to the next speaker. Any questions? Okay, thank you very much for your presentation. It was very enlightening, and we hope to see you more in our meetings.
It would be a great pleasure. Thank you very much again for the invitation, and I'm following the meeting. It's really nice. Congratulations for it.
Thank you very much. We have been honored by your contribution. Now we have Dr. Mohsen Hijab. He will present us the microbiome in health and disease in a nutshell, because the topic is so extensive. Dr. Mohsen Hijab, PhD, is a molecular biomed scientist specializing in animal model of human diseases and microbiome science. He's a Max Planck Institute. He works in the Max Planck Institute for Evolutionary Biology in Kiel, Schleswig-Holstein, Germany. He has a long experience in design, optimization, troubleshooting of analytical assays, and as well as bioinformatic analysis, interpretation of next generation sequencing, the data sets from fecal and tissue associated specimens, while acquiring a vast hands-on experience in specimen collections. He has an extensive background in invertebrate, the Drosophila based in vivo screening for small molecule drugs with anti-inflammatory properties, prebiotics, and the probiotics. I think he's entitled to talk about the microbiome in health and disease, and we expect his presentation to put all this colossal subject in a nutshell. So the task is difficult, Dr. Mohsen. We're pleased to have you, and please go ahead with your presentation. Thank you for accepting our invitation.
You're welcome. Good afternoon, everybody. I'm really delighted to receive your invitation to talk today about the microbiome in health and disease. My name is Mohsen Hijab. I studied molecular genetics at the National Research Center in Egypt and Lübeck University in Germany. After that, I completed my PhD in host microbiota interaction in animal model of inflammatory bowel disease. I believe that I feel that I am lucky to work at the intersection of genetics and the microbiome and navigate both worlds, the world of genetics and the world of microbiome. And I will touch on this topic at the intersection of genetics and microbiome. I will touch on it in my presentation. The agenda for today is started with reflecting on how medical genetics, especially the genome-wide association study, shaped our microbiome research, and we'll navigate together the microbiome world, and we will talk about the microbiome from the lens of scientists and politicians, and how sequencing technology can drive microbiome application. And with the most important part is the major concept of clinical microbiomics and the understanding of microbiome studies in inflammatory diseases. And after that, I will touch on an example of gout and we'll end up with a QA session. I started my first leg in genetics world in Lübeck in Germany, studying genome-wide association study of rheumatoid arthritis. And I will summarize the benefits of genome-wide association studies. And how a genome-wide association studies paves the way for successful microbiome research. As we know that genome-wide association studies is for identification of variant associated with diseases or treatment outcome or different traits, and also genome-wide association studies moved to touch on trans-ethnic disease signature. So across the genome-wide association study across different population and within the same population. And after that, fine-tuning of genetic architecture. And the most important thing is the genome-wide association study help us in drug repurposing. This was a new thing in the pharmacology and treatment of disease. And the example here is genome-wide association study. Genome-wide association study of psoriasis has reported a significant association of interleukin-23 receptor gene, and when it was replicated on another phenotype, which is Crohn's disease, it shows the same association. And as we know that ustekinumab is successful in treating psoriasis, and when it was repurposed to treat Crohn's disease, it was successful. And drug repurposing based on genetic test was new in the field, and the similar trend will be followed in microbiome as well. The next point is bigger is better. So everyone was curious about the sample size, better large sample size, the same thing we need in microbiome as well, and the establishment of national biobanks. And also these biobanks, which is established before, was used for microbiome research, collecting fecal material, saliva, etc. And also advancing the field of biostatistics and bioinformatics. Bioinformatics at that time was new in genomics, and after many GWAS studies across the globe, there are a lot of very skilled bioinformatician and biostatistician, which move later to microbiome research, and also the meta-analysis. And the most important thing is GWAS help us to develop new platform of omics, such as transcriptomics, proteomics, and lipidomics, and metabolomics. By time, geneticists geneticist, the scientist or geneticist finds that they touch only the tip of the iceberg. As I see, the story is only half if they told from one side. We focus on genetics, which is the top of the iceberg, and what is beneath is overlooked. And what is beneath is more than genetics. It's an exoposome. There's a food, environment, lifestyle, circadian rhythm, microbiome, and a lot of interaction occurring in the bottom of iceberg, and this is also, this interaction is reported to be a driver of many inflammatory diseases. The beauty is the scientist has established a new paradigm for post-GWAS of complex diseases, which is so-called post-GWAS era or GWAS follow-up studies. It's the same. And as we see here, on the right-hand side is the host genomics, it's a host genetics, and on the left-hand side is the microbiome, and on top is the environmental factor. The environmental factor can hit both the microbiome and the host genetics. Also, host genetics and the microbiome can affect the host phenotype. The host phenotype could be a disease per se, or could be a treatment outcome. And the host genetics and the microbiome can affect the host phenotype directly or indirectly via host gene regulation or epigenetics. The most important thing here, as we can see here, the host genetics is static, but the microbiome is dynamic. And the arrow, the left-hand side, we see the arrow is bidirectional because the microbiome can affecting the host and the host can affecting the microbiome. And a great deal of work is nowadays in ongoing research to study which controlling which. Recap of the first section is EGYSIR study of inflammatory and autoimmune disease help us to provide international disease consortia, biobanking expertise, sequencing platform, technical expertise, and bioinformatics and IT infrastructure, storage capacity, for example, and best practice for association, from association to function, from correlation to causality. And this paves the way for successful future microbiome research. This is my message, is genome-wide association study paves the way for successful microbiome research. So we have to, we switch gear to the microbiome world. I did my host microbiota studies in the University of Kiel. And the University of Kiel at that time was a German research hub for evolution and microbiome science. And I cultivated a mindset of hologenomics or metagenomics. And by definition, the holobiome comprises both the genome of the host, the human genome, and the genome of the symbiotic microorganism, the microbiome. And this is also one unit. It's one unit. It's one organism. We cannot live alone. And the second thing is thinking about the gut. So the gut microbiome is not only controlling the gut physiology, but controlling distant organ as well. And I will touch on it in 2 minutes. So navigating the microbiome world. Microbiome. What does a politician see microbiome? So it's funny that many politicians collecting their booths during the trip and don't like to leave it because they are afraid of someone can analyze it and get inference of behavior, for example. Also, the Korean president do the same as well. And this is from the politician view. So the politician see microbiome beyond the gut. It's not only the gut, it's beyond the gut, that controlling behavior as well. What about the scientist, the basic scientist? Excuse me, it's here, it's something wrong? Okay, excuse me. So the beauty of research of invertebrate model organisms. I cannot see it, but I can tell you. So there are a lot of invertebrate model organisms like C. elegans, Drosophila melanogaster, and squid vibrio. And working on these invertebrate model organisms has established the science of host microbiota interaction many years ago. And ongoing research on these animal models will shape our understanding of the host microbiota interaction, the metagenomes, and in health and disease as well. And one of my favorite mentors is Professor Thomas Bosch, and he is active in the field of metagenomes. And this is his message. His message is understanding the multi-organismic nature of life. All organisms are meta-organisms. Disrupting the interaction within meta-organisms are the major causes of many chronic and inflammatory diseases. The idea is, as I said before, the meta-organisms or the holoorganisms are the host genetics, the host genome, and the microbiome. And this is true because losing a microbial community can cause disease, and replacing it and restoring it can treat disease. As we know that fecal microbiota transplantation show success in CDE, in Clostridium difficile infection as well. So sequence technology drive microbiome application. This is true. As we can see, the sequencing paves the way for the human genome, the first draft of Human Genome Project. Also, the invention of next generation sequencing paves the way for the Human Microbiome Project. And as a rule of thumb is there is an inverse relationship between the sequencing cost and number of reported studies on microbiome or genome. Microbiome science, major concepts. So I will talk about major concepts in microbiome science. This concept should be kept in mind because people working in microbiome do a lot of descriptive research and didn't dive into the microbial ecology. What is microbiome and what is the microbial ecology and what is the major concept in this science? So let's start with defining the microbiome. Microbiome and microbiota are interchangeably used, but a precise definition of microbiota is the collection of all microorganisms. Long story short, it's microbiota is a cells. If we talk about microbiota, you talk about the cells. On the other hand, the microbiome containing both the cells and the cellular component, the molecules within the cells. It could be metabolites, it could be signaling molecules, it could be structural element, it could be ribosomes, for example. This is microbiome. As such, we can say microbiome is generalized definition. And as we see in the figure here, microbiota is could be a bacteria, algae, could be virus, bacteriophage, for example. And the microbiome is both the molecules, the bacterial factors, and the cells itself. The human microbiome, the superorganism concept. We are superorganism. So we are superorganism. A superorganism is the same as a holobiome. So our superorganism is that we are, as we see here in the figure, we have more bacterial genes than our genes. We have 10x bacterial genes than the host genes and the host cells. And there are a lot of people describing microbiome as a lost organ. Do you agree or not? I don't agree, because it is not an anatomical entity. But I can see it's a microbiome is our second half. I agree with that. Microbiome is our second half. Or I can say microbiome is a virtual sub-organ within the organ. It's a very dynamic, so it's not a signature. People say it's signature. It's a cloud. We can say it's a cloud. It's not a signature because it's changing over time. Microbiome, the dark matter. Microbial dark matter. So we read a lot in the books that microbial dark matter. What's microbial dark matter? The microbial dark matter refers to the majority of microbiome that microbiologists cannot grow under lab condition. And if we see here, this is a taxonomy pinning from 16S microbiome sequencing. As we see a lot of microbial community here, but we cannot grow it on a petri dish like our traditional petri dish in the microbiology lab. And for that, a lot of attempts to culture the human microbiome are going on. And this is attempt so-called culturomics. People are interested to culture the unculturable microbiome. Why they are interested in that? This is simply one of the methodology is working with a metabolome and to infer a molecule or a nutrient that could be enriched in the media, and I get trained on this single cell genomics, and it's very complicated, and most of the people working on it is working on soil microbiome, not clinical microbiome. And why we need to culture the unculturable microbiome? I would say the uncultured microbiome, because it could be culturable in the future. And one of the application is to colonize germ-free mice. There is no germ-free mice, because I told you that we are whole genomes. There is no organism without microbes. But in lab, we have germ-free mice. We can generate germ-free mice, and I can colonize a single microbiome or a cocktail of microbiome in the germ-free mice for a proof of concept experiments. So idea is if I have a previous experiment and with 16S sequencing, so the hit is microbiome that is uncultured. And to validate my experiment, I can colonize the germ-free mice and test the phenotype. The other application is simply to have, sorry, this is not the right one, because I don't like to show marketing, is probiotics. I will talk about the microbiome from pathogenicity to symbiosis. The most important thing is most of the microorganisms are essential for ecosystem functioning. The ecosystem here, the ecosystem would be the gut, would be the skin. Every organ is an ecosystem or a niche that the bacteria colonize. It's called ecosystem. And most of the bacteria, or most of the microbes are essential for ecosystem functioning, and few of them are pathogenic. And I'm kidding with one of the kids in my family and say, are you a microbe? He said, no, I'm not a bacteria. Are you a bacteria? No, I'm not a bacteria. I told him that the bacteria is also beneficial. It's not a pathogenic bacteria. And this is concept should be bear in mind. And here, as we can see, the bacteria compete and cooperate. And it depends on the availability of nutrient. Based on the availability of nutrient, the bacteria can compete together or can cooperate. And one of the cooperation is the cross-feeding. Cross-feeding means that bacteria metabolites can feed to the another bacteria and to grow. And this is a cooperation. And the competition, they compete for the niche. So they compete for the space to colonize. And let's talk about the human microbiome, the function. As we studied in microbiology classes, microbiome is important in the food digestion and the production of short-chain fatty acid, bile acids, vitamin K, etc. But one of the neglected aspects of microbiome is that the microbiome bears colonization resistance to pathogen, which is true, because probiotics is recommended for patients with antibiotic-associated diarrhea, because they should take probiotics to restore the ecosystem to avoid any invasion from other pathogenic bacteria. So this is a colonization resistance. Also, microbiome detoxifies environmental hazardous substance. Also, microbiome play a major role in maturation of host immune system, both innate and acquired immunity. But it's a big topic. We can have a separate talk on it. The microbiome is also important in mucosal barrier homeostasis because of lack of microbial balance, lack of eubiosis. I will talk on it later. Lack of proper microbial balance can cause leaky gut, and leaky gut can cause translocation of bacteria from the gut lumen to the circulation, causing a low-grade inflammation. Here is also the concept that the microbiome is multi-directional and communicational as well. So microbiome has many connections. Microbes, there are a gut-brain axis, a gut-heart axis, lung axis, and also muscle-bone. But I see there is here one thing missing, which is the eye. There are also eye-gut axis. And we have a project to audit, and we hope to prove that there is a one direction or bidirection eye-gut axis, because some axes are two-way traffic. It's not only unidirection, could be bidirection. And in uremia, for example, I read a paper on uremia that the uremia can affect the gut microbiome, and the gut microbiome disturbance can cause uremia as well. One of the important aspects of microbiome is dynamic in time and scale. For example, the microbiome is affected by food. Food is a major modifier of microbiome, and it's also affected by circadian rhythm. And also there are spatial dynamics in space. Simply, the microbiome in the small intestine is different from the microbiome from large intestine. The microbiome in forearm is different from the microbiome from the hand. And this is important for people doing experimental microbiome research, and they can choose their sampling where they can select the habitat. And also the gut microbiome, there are a biogeography of microbiome. So as we can see here, there is a difference along the gut in terms of pH and partial oxygen pressure and the bacterial load as well. And also here, the large intestine versus the small intestine, there are difference in the production of IgA, the production of antimicrobial peptide, and the colonization of bacteria. The large intestine is largely colonized by Ruminobacterius species, and the small intestine are colonized by Enterobacteriaceae, for example. One of the most important aspects of microbiome ecosystem. I say ecosystem because it is a system. It's a balanced system. There is an interaction going on in order to balance the system. And the first aspect is eubiosis and versus dysbiosis. Eubiosis is a proper balance of microbial community. Dysbiosis is the imbalance of microbial community in terms of richness, the composition, and in terms of the diversity. And as we can see here on the left-hand side is this eubiosis. So a lot of microbial species, and there are a diversity within the ecosystem. And if we go if we go to the right-hand side, we see dysbiosis, less microbial community and also not diverse. And if we read a paper on microbiome and read about dysbiosis or dysbiotic community, it's due to the lack of eubiosis. And the second aspect is the response to perturbation. This is one of the overlooked aspects in microbiome science, is to test for the resilience and the resistance. So the important one is the resilience. Resilience means it's also in psychology. This term we got it from psychology. The resilience is the ability of the community to bound back to the initial stage. So if we have a stress on the gut microbiome due to drug, due to food, due to emulsifiers, due to different things, and after that due to disease, inflammation, after that the microbial community change. And after treatment, can the treatment restore the microbial community to the initial stage? You can test it. And if you understand this concept, you change the way you design your experiment. You don't go for cross-section, you will go for longitudinal study design, because you have to have one sample time point before treatment and another sample point after treatment to test is there a resilience or not. Also, gut microbiota and intestinal permeability and systemic inflammation is one of the most important aspects in microbiome study. For example, colchicine and non-steroidal anti-inflammatory drugs was reported to have a collateral damage on both the gut microbiome and the intestinal mucosal barrier. And as we can see here, if there is a disruption of the tight junction or the tight junction, there is a leakage. Would be a leakage here, the left-hand side, the leaky gut syndrome. There is a leakage of microbiome or the leakage of lipopolysaccharide from gram-negative bacteria to the circulation, and this is induce low-grade systemic inflammation. This is the most important slide you should keep in mind. It's understanding microbiome study. So I collect what's common in different microbiome studies. So major parameter reported in microbiome studies, one of them is reduced bacterial diversity. As I said before, dysbiosis. This is one of the aspects to characterize your microbiome. The second thing is the ratio of the phyla, Bacteroidetes and Firmicutes, FB. Is widely accepted as a proxy of intestinal homeostasis. And if there is a reduced ratio of Firmicutes to Bacteroidetes, it widely reported in autoimmune and inflammatory diseases. The third point is there are pro-inflammatory related microbe, is notorious microbe. So if you see bacteroids and Profitella corpi, you will see it's a lot in inflammatory diseases. On the other hand side, there are anti-inflammatory related microbe, which is probiotics like Bifidobacterium and Faecalibacterium species as well. What about Bifidobacterium? Bifidobacterium is a gram-positive lactobacillus lactic acid bacteria. And the Faecalibacterium is a gram-positive bacteria reported to produce short-chain fatty acid. Short-chain fatty acid like acetate, butyrate, is the most important nutrient to the colonocytes. And SCAFA or short-chain fatty acids are absorbed by host cell and stimulate the immune system. It affects also the stability of the gut permeability. The last point is lipopolysaccharides, the LPS of gram-negative bacteria. It's reported to elicit toll-like receptors and trigger the inflammasome. And this will cause release of pro-inflammatory cytokines like TNF alpha, IL-1 beta, and this will trigger low-grade systemic inflammation or due to bacterial translocation. If you understand well, I will go back. If you understand this parameter well, you can read any paper on clinical microbiome, or you can write the chapter like us. This is our chapter on the role of probiotics and microbiome in gout. And as we see here, probiotics have multiple functions, can affect the uric acid degradation and secretion, and can cause restoration of gut dysbiosis, and can cause also purine absorption and metabolism, and will affect the fermentation of phytochemicals that is used in anti-gout diet. Recap for the second section is all organisms, again, all organisms are sober organisms, and disrupting the interaction within this meta-organism is the major cause of many inflammatory diseases. In most cases, patients with inflammatory bowel and autoimmune disease, inflammatory and autoimmune disease, having a disrupted microbiome ecosystem, the composition, the diversity, and the resilience. The most important part, microbiome change over time. And also, when you prescribe medication, you have to have a look. Is this medication causing barrier integrity or causing microbiome dysbiosis? And a group of people in Heidelberg is working on that, and they will provide in the future a database of pharmacomicrobiotics, is the effect of drug on microbiome and the effect of microbiome on drug, because it's bidirectional. Microbiome can degrade drug, and the drug can cause dysbiosis. The last thing is the microbiome was reported to axis with a sustained organ. So the gut renal axis, the gut eye axis, gut heart axis. So keep in mind that there are a lot of scenarios behind the gut. I did not present my data today because I did a presentation for introduction. But I believe that one should acknowledge people staying behind him, pushing him across the career path. And with that, I thank Professor Gafar Ragab for continuous and sincere support. And also Dr. Weiliger, this was my previous supervisor, Professor Thomas Oder, and the organization that broadened my scope in microbiome science and in metagenomics, like DIMB, the German infrastructure, bioinformatics infrastructure, and the Graduate School of Meta-Organisms. And thank you for attending my talk, and I'm happy to receive questions.
Thank you very much, Dr. Hagab. That was very beneficial in shedding light on this complex topic. I think we have a time for just one question, if anyone would like to ask. Okay, Dr. Dina, please present yours.
السلام عليكم. أنا دينا شاهين, Professor Rheumatology Immunology, Mansoura University. I would like to thank you, Professor, for your talk. I just interested in one point. You have said that colchicine causing gut microbiome leakage and causing systemic inflammation.
Yes.
I stand right?
Yes, it was reported that colchicine.
Yes, actually, we use colchicine to control the state of inflammation in gout,
Yes.
in familial Mediterranean fever, in sometimes inflammatory osteoarthritis. So I'm questioning how that comes. Is this contradictory condition?
Okay. Shall I answer, or do you have another question?
Yes, you can.
Okay, the idea is we're prescribing that because we don't know, because the new science is emerging. So in the future, pharmaceutical company will design the drug based on the microbiome, and can modify the drug based on the microbiome activity. So a lot of in vitro microbiome research is going on in that. So you prescribe colchicine because it's the only medication, but it's causing something. It's causing something you don't know. It's affecting the intestinal permeability. So the idea is that you can mitigate that. You can mitigate that with, you can prescribe the right dose, or you can offer a nutritional supplement that stabilizes the gut permeability.
Maybe is this occurring when we exceed the therapeutic dose? Sometimes we have been faced with many patients when taking colchicines, they are intolerant. They having abdominal pain, diarrhea, crampy pain with diarrhea. So this may be intolerance, sometimes allergic, maybe, or what, I don't know.
I have no clue about it because I didn't do it experimentally. But you can say it could be the side effect, or it could be the intolerance could be referred to the individual microbial community. But to prove that, we have to have a study on it. You got what I mean? I don't have a proof of concept on that, but it could be.
Thank you.
Okay, thank you, Dr. Dina. The case is that a drug can have some paradoxical effects in the gut other than what it does inside the body. It stands correct as well regarding the effect of food items or the functional foods, the diet. Some items are considered harmful, for example, for gout, but in another context or in another circumstances, it may be helpful to help in the kidney excretion or in lowering down inflammation. Perhaps it's harmful due to its content of protein or purines, but it may be anti-inflammatory in nature. So we have the outcome as a combination of many factors. Colchicine also may be may not show response in FMF, and we have presented data that the genotype of the patient may influence his or her response to colchicine, other than the intolerance case. So thank you very much, Dr. Hagab. very beneficial presentation,
Thank you
and
for
thank
the
you
invitation.
for joining the meeting. We hope we can meet again in future meetings.
Thank you.
The last presentation is a recording, so we'll not be having time for questions. Professor Atkinson, I will present him. He sent his recording because of some obligations that he couldn't come by himself. The other point is that he preferred to present a different title than the original one. This is a smaller aspect of the whole issue or the whole topic of immune deficiency in health and disease. He said, I think that will be like swimming in an ocean. So he preferred to discuss an angle of this topic as immune deficiency and autoinflammation in rheumatic diseases. T. Prescott Atkinson, or Professor Atkinson, is a clinical consultant of the UAB Diagnostic Mycoplasma Laboratory and with expertise in pediatric infectious diseases and immunology. He is the director of pediatric allergy and immunology at Children's Hospital of Alabama, and he's a professor of pediatrics at the UAB, the University of Alabama at Birmingham. He's board certified in pediatrics as well as allergy and immunology. Dr. Atkinson is a key opinion leader in mycoplasmology, the mycoplasma organism, and author of more than 70 research articles and current president of the United States Organization for Mycoplasmology, the USOM. His major ongoing research interests include the role of chronic molecule infections in chronic diseases such as asthma and arthritis, and in patients with primary immunodeficiency. Dr. Atkinson was the chief editor with me in our first book, my first book on the microbiome in rheumatic disease and infection, and his insight was very helpful in designing the table of contents, and he contributed many beneficial chapters as well. So I leave you with the recording of his immunodeficiency and autoinflammation in rheumatic disease.
Well, good afternoon. My name is Prescott Atkinson. I'm a professor of pediatrics at the University of Alabama at Birmingham, in Birmingham, Alabama. And I work at the Children's Hospital there. I'm primarily a pediatric immunologist. And so I'm going to talk this afternoon. My talk was supposed to be on the diagnosis and management of primary immunodeficiencies, but I decided that that topic was too enormous to really do very much good, and that I would focus it on primary immunodeficiencies as they relate to rheumatologic disorders, things that practitioners are very likely to encounter in their practice, and hopefully provide a little bit of helpful information for you in these patients, these very sometimes very challenging patients. So I'm going to go ahead and start my presentation here. So the title is really immunodeficiency as it relates to autoinflammation in patients with rheumatic diseases. And I apologize in advance for telling you things that you may already know throughout this talk. Some of you may be very familiar with some of these things. And I just wanted to mention that clinical immunology really is part of the field of immunology that we all share as rheumatologists, clinical immunologists, and allergists. We're all really looking at different aspects of the immune system, and many times those patients can have multiple aspects of the same manifestation of the same dysfunction in the immune system that's causing untoward reactivity towards external antigens, self-antigens, and deficiencies related to immune function that cause the patient to be more susceptible to infection. So, and all of these disorders have become, or our understanding of them has become more and more complex over the last decades, so that really it's best to consult a specialist in these disorders if your patient is having difficulties related to those things. Rheumatologists wouldn't think of doing, or most rheumatologists wouldn't think of trying to do allergen immunotherapy for allergic rhinitis, and allergists would not think of tapping a patient's joint if they had fluid and inflammation there. And it's the same really with immunodeficiencies. When patients come to my clinic, I am usually seeing parents whose child has been having infections, most commonly respiratory infections, but sometimes a whole variety of different types of infections. And we use the pattern of those infections to really guide our diagnostic workup to try to be as efficient as possible. Of course, the one at the top of the list here, severe combined immunodeficiency, is not one that usually walks into your office. Those are babies that are born with very severe immune deficiencies that are now in most places picked up by newborn screening, hopefully. And so life has gotten a little better. We can diagnose them very early now and hopefully get them on to treatment, usually bone marrow transplant. But all the rest of them require sort of a diagnostic odyssey with testing for function and sometimes genetic testing to try to identify an underlying defect if there is one. Antibody deficiencies are most common, over 50%, but there are a whole variety of other types. Innate immune deficiencies involving the phagocyte or complement compartments that usually can involve respiratory infections, of course, but also deep tissue infections like osteomyelitis or abscesses, defects in cellular immunity, NK cells and cytotoxic T cells. Really, the hallmark of those types of disorders are problems with viral infections, especially herpes viruses, but also cutaneous viruses like papillomavirus. And the most complex and challenging group of disorders now exploding in our field are those of combined immunodeficiencies that are most complex and difficult to diagnose without genetic testing. When we see a patient with immunodeficiencies in clinic, we have to bear in mind that there may not be anything wrong, or I beg your pardon, if we see a patient with recurrent infections, there may be nothing wrong with the immune system. The patient may have some functional problem or some metabolic problem, primary aspiration, asplenia, for example, cystic fibrosis, the ciliary dyskinesias, infections such as HIV, we can't forget about. Some malignancies like B-cell CLL can cause significant B-cell deficiencies. Chronic kidney disease or nephrotic syndrome can cause secondary immunodeficiency. And of course, we, the doctors, are the culprits in causing immunodeficiencies in many of our patients with our cytotoxic drugs, our biologics, our drugs such as cyclosporin and tacrolimus, and transplantation of solid organs and bone marrow. So, but the focus of this talk is really going to be on inborn errors of immunity and how they relate to. I'm going to try to make some points. Our general focus will be to try to make the point that rheumatologic manifestations of these diseases are not uncommon at all, and something to bear in mind when you're seeing a patient and treating the patient for rheumatologic features is to consider that there may be an underlying immunodeficiency that's related to it. When I came to UAB in 1992, there were very few well-defined genetic immunodeficiencies or inborn errors of immunity, as they're now called. Now we have almost 500 that are well-defined, and the curve is not leveling off yet. We're anticipating there'll probably be at least twice this many before all is said and done, if that ever happens in the future. And as I mentioned, many of these disorders have associated autoimmunity. This is a recent paper from 2024 in which the authors pre-selected 18 inborn errors of immunity with a total of over 1,000 patients and analyzed their phenotypes for different manifestations, including a number of autoimmune problems. And you can see that those range anywhere from 10% to maybe 30% in these disorders. So they're relatively common, and that just underscores the fact that you have to bear this in mind when you're seeing a patient. And I'm going to go through a group of or a number of examples of these. It's not meant at all to be comprehensive with almost 500 disorders out there. It would just be an overwhelming task to try to cover that in 40 minutes, but I'm going to just touch on a few interesting examples here that I think could be instructive, and just to remind you of how these different aspects of immune dysfunction can result in autoimmunity. I'm going to first talk about primary immunodeficiency. Primary antibody deficiency disorder called common variable immunodeficiency, which is notoriously associated with autoimmunity, and then move on to looking at quantitative defects in T cells with a couple of examples. DeGeorge syndrome, a primary problem with the thymus, and RAG1 and RAG2 deficiency, which are relatively uncommon, but are well described to cause autoimmunity when you have partial defects in these genes. And then we'll look at quantitative defects in regulatory T cells, the poster child FOXP3 deficiency, or IPEX. I'm going to touch on AIR, the autoimmune regulator, and its role in causing a defect in central tolerance. Again, another really good example of how a single gene defect can cause multiple problems with autoimmunity. Then we'll talk about the autoimmune lymphoproliferative syndrome and ALPS-like disorders, which cause problems with inflammation, lymphoproliferation, and autoimmunity. And lastly, I'll talk about the hemophagocytic syndromes, which are associated with HLH and macrophage activation syndrome. So first, to talk about antibody deficiency syndromes, these are the most common types of inborn errors of immunity that we see as clinical immunologists, and their manifestation is primarily respiratory infections. So it's the most common type of presentation. There are a number of well-defined genetic disorders, but many patients with antibody deficiencies, we either cannot identify a single gene, or it may be part of a syndrome. We see many patients with syndromic antibody deficiency who, as a part of the syndrome, of a complex syndrome, have antibody deficiency as part of that. So there are several different types. I'll talk about them in a second, but a little bit more. But agammaglobulinemia is, as it would suggest, is an absence of all of the immunoglobulins, because you have some sort of defect that's causing a complete deficiency in the development of B cells. Common variable immunodeficiency, the one I'm going to really focus on a little bit, is defined as a reduction in at least 2 of the main serum immunoglobulin isotypes, IgG, IgG, with either IgA or IgM or both, with usually relatively normal numbers of T and B cells. Hyper-IgM syndromes are problems with isotype switching, so they have elevated IgM and reduction in serum IgG and IgA, sometimes profound reduction in those other immunoglobulins, because you have a problem with isotype switching. Then you can have isolated isotype or light chain deficiencies with, again, normal numbers of B cells. Many times there may not be really a very significant immune deficiency identifiable at all with these types of defects. And finally, a disorder that's called specific antibody deficiency, in which the patient has normal immunoglobulins, normal numbers of B cells, and yet when you test, the patient is having infections, many times severe infections with pneumonias. And when you test the patient with vaccines, for example, especially polysaccharide vaccines, they're deficient in making antibodies. So something is broken in the machinery, even though the car looks normal sitting in the driveway. As I tell parents, something's broken under the hood, and it's just not running. It won't. One of the many signals that's needed to produce functional immunoglobulin after an infection or after a vaccine is broken, and there's a loss of function. So I like this cartoon. This is from a paper by Charlotte Cunningham Rundles and colleagues back in 2005. So it's a little bit dated, but it still actually fits rather well. There are genes like JAK3 and gamma C that are involved in B cell development, early B cell development, but also in other cell lines, such as T cells and NK cells, for example. And then there are a group of genes like the RAG genes, RAG1 and RAG2, Ig alpha, Ig beta, Ig mu, lambda 5, which are required for the development of pre-B cells. So you have a block early on at the pro-B cell stage. Then there's another well-known gene, BTK, the Bruton's tyrosine kinase, which is essential for passing this block from this stage from pre-B cells, where you have the light chain, the replacement light chains, to a fully developed but immature B cell. So you have a block at the pre-B cell stage in this, with defects in this X-linked gene, which causes X-linked agammaglobulinemia. Next is after the development of mature B cells, which have both IgM and IgD on their surface, you can have blocks caused by a number of genes that are required for isotype switching. And these are genes that cause, for example, selective IgA deficiency or hyper-IgM syndromes, in which you're really locked in the IgM phase and can't make any of the other isotypes. But the most common, now over 60 genes have been associated with common variable immunodeficiency-like disorders. And this is a terminal differentiation defect. You have mature B cells, but something is not working, and that's required for differentiation, for response to T cell stimulation and antigen to produce a productive antibody response with differentiation into plasma cells and memory B cells. And when you look carefully at these B cells, you see that they're usually, or very frequently, decreased numbers of memory B cells, because that's part of this differentiation process that's not working properly. And that's common variable immunodeficiency. So classically, you really have to, for definition purposes, you really need to have a low IgG and at least one other isotype Often the patients also have lymphadenopathy and splenomegaly. There are no clear abnormalities in T and B cells, generally speaking. They typically present with a history of recurrent respiratory infections, sometimes severe recurrent pneumonias, or maybe it may just be chronic sinusitis or recurrent bronchitis. They may have some GI problems, diarrhea, especially due to giardia. They have a tendency to develop autoimmunity and lymphoid malignancies. Even though we have over 60 genes that are associated with a CVID-like phenotype, the majority of patients with true CVID, we really don't have a single gene. We don't identify a single gene in many of those patients. We can't find one, and there's a suspicion in the community that some of these patients may actually have an autoimmune cause for their common variable immunodeficiency. They've made some sort of autoantibody that's interfering with the production of a productive antibody response. And along those lines, there's a linkage to the class 3 region, which would also be seen in patients with lupus, for example, sort of highlighting the possible role of autoimmunity in this disorder. This is a disease that often sandbags adult physicians because it tends to occur in adolescents or young adults, although it can occur at any time, even in older adults. And so the adult physician is seeing a patient who hasn't had a diagnosis of immunodeficiency previously, now is having some autoimmunity problems and may, or perhaps has developed chronic ITP, idiopathic thrombocytopenic purpura. And so the hematologist or the rheumatologist is treating a patient who really has an underlying immunodeficiency that's evolving, but is sort of lulled into thinking that this is some kind of primary rheumatologic problem that's just developed as the patient's gotten a little older, never dreaming that the patient is really on his way to developing a really severe antibody deficiency and may be at risk for severe infections. Most patients with CVID, the large majority, probably 80% or so, don't really have any serious problems once they're placed on immunoglobulin replacement. But a substantial subpopulation of them, I've seen more numbers that are closer to 15%. This one is a little higher, but there's autoimmunity and inflammation in this subgroup, sometimes life-threatening, with cytopenias, lymphoproliferation, autoimmune enteropathy, and a whole range of other autoimmune problems. This cartoon sort of highlights that. The main problem that CVID patients have before they're placed on appropriate immunoglobulin replacement is with respiratory infections that can produce chronic respiratory insufficiency and eventually death if it's not treated appropriately. They have a tendency to develop a range of GI problems. They're notorious, along with other hypoimmunoglobulin patients, for developing septic arthritis with mycoplasmas and ureaplasmas. And these infections can be very slow-moving and indolent, and can lull the unsuspecting rheumatologist or orthopedist into thinking that this is an inflammatory arthritis rather than an actual infection. They don't have cell counts many times that you would expect with a bacterial infection, but although they're slow moving, they can be extremely destructive and very difficult to treat and repair once they've really gotten going. And then there, as shown here, there's a whole range of inflammatory and autoimmune conditions that can be seen in this smaller subgroup of patients with CVID, and could be the presenting. Many patients with CVID, for example, will originally present with autoimmune cytopenias. It's very common for them to be seen initially by hematologists and treated for some time before it becomes obvious that there's something else going on, and eventually they get diagnosed and placed on immunoglobulin replacement. So much for antibody deficiencies. I'm going to turn my attention now to T cell defects. And I wanted to talk for just a minute about the DeGeorge syndrome, one of the most common types of T cell deficiencies that we see because of this chromosome 22q11.2 deletion syndrome, which is the most common significant microdeletion syndrome. I think it's somewhere around 1 in 2,000. We see them all the time here at UAB because it's a big congenital heart center. DeGeorge syndrome is one of the ways that you can develop the patient has developed thymic hypoplasia or aplasia. There are other genes that can do this. FOXN1 has been described. Haploinsufficiency of this gene causes a variable ectodermal dysplasia as well as a variable degree of thymic hypoplasia. And the numbers of T cells that you make every day are proportional to the mass of the thymus. So the smaller the thymus, the fewer T cells you're making. And when you reach the point where you really have aplasia, you have essentially severe combined immunodeficiency. Unfortunately, a disease that can't be treated with a bone marrow transplant, a hematopoietic stem cell transplant, has to be treated with thymic transplant. Very difficult procedure done in only a very few centers around the world. Unfortunately, this condition is somewhat more common, at least in our center, than severe combined immunodeficiency. So it's really problematic. We described another type of deficiency a few years ago called FOXI3 haploinsufficiency. That's really a variant of DeGeorge syndrome. Pardon me. And this also can cause very severe thymic hypoplasia or aplasia on occasion. This is a typical, this is a picture of a patient with the 22q microdeletion syndrome. The thing about DeGeorge syndrome that I wanted to mention is it's relatively common. Severe T cell deficiencies associated with it are not common. But the incidence of autoimmunity is substantial. 8.5% in this series of 130 patients, which is far higher than is seen in the general population of children, of course. And it really tends to be the most common in patients with the lower numbers of T cells, particularly the naive T cells. I wanted to talk about one other disorder in which you get autoimmunity associated with low numbers of T cells, low T cell production. And this is with the recombinase activating genes, RAG1 and 2. This process, of course, can happen with any type of partial SCID disorder. It's just that this one has been particularly well described. So the RAG genes are enzymes that are required for VDJ recombination, for productive rearrangement of the T and B cell receptors. When they have completely absent function, either RAG1 or RAG2, they cause a severe combined immunodeficiency, T negative, B negative SCID, and they represent about 11.5% in some studies of severe combined immunodeficiency, depending on what part of the world you're looking. But it's been well described that in addition to causing severe combined immunodeficiency, there are other syndromes that we see depending on how much function. If you have hypofunction of one of these alleles, you can get what's called Omen syndrome, which is really a SCID disorder, but it's a leaky SCID. And so there are some T cells there, and you get sometimes massive expansion of a very few clones of T cells with no regulation. They're rogue T cells, and they cause tremendous inflammation and primarily are really everywhere, but most obviously to the during their diagnostic phase in the skin and in the GI tract with autoimmune enteropathy, and really requires immunosuppression with steroids and cyclosporin, things like that, while the patient's on his way to a bone marrow transplant, because this is a lethal disorder, just as lethal as severe combined immunodeficiency. But milder forms have also been described, in which the patient may have relatively normal numbers of T and B cells, relatively normal repertoire, and yet has increased problems with autoimmunity, including granulomatous autoimmune features, sometimes that can mimic granulomatous polyangiitis. This type of patient, you're really only going to be able to identify, most likely, by genetic testing. But this is autoimmunity related to a dysfunctional immune system because of partial defect in this in these important genes. And again, these are really just examples. You can probably get exactly the same type of process with other types of SCID genes with partial function. Now going to talk about regulatory T cells, the transcription factor, which is sort of the master transcription regulator for the development of regulatory T cells, or Tregs, is FOXP3, and it causes an X-linked syndrome called IPEX, immunodysregulation polyendocrinopathy enteropathy X-linked syndrome. And usually occur, typical presentation is early in infancy. Patients, we saw a patient not several years ago at our center who was born with type 1 diabetes, had the typical features of severe autoimmune skin disease, enteropathy, and did not survive to make it to bone marrow transplant. These patients really don't have an immune deficiency per se, but they do die of infections frequently because of their inflammatory problems with their skin and GI tract, causes barrier problems. They just have a complete lack of regulation of their T cell activity and just raging autoimmunity. There are a number of cases that have been published where milder forms of this condition produced a phenotype, quite a variable autoimmune and inflammatory phenotype. And there are also genes, a number of other genes, at least a dozen other genes that have been described that can produce, and others that have not, are unknown, that can produce an IPEX-like syndrome. So you can get a lot of the same features, low regulatory T cells, lots of autoimmunity, and some of these other features. So this just shows some of the features for typical IPEX and some of the things that have been described for the patients with milder disease. Food allergies are very common, and eosinophilic gastrointestinal disease, a variety of different types of endocrinopathies, arthritis, cytopenias, and even hypogammaglobulinemia have all been described. This is a recent paper which was documenting some of the diagnoses that had been entertained in some of these patients with late onset diagnosis of IPEX-like and IPEX-like disease. Some of them were diagnosed with IPEX initially, but initially other things were being considered: severe food allergies, enteropathies, lupus, ALPS, severe combined immunodeficiency, APOSED, which I'll talk about in just a little bit, cystic fibrosis, common variable immunodeficiency, combined immunodeficiencies, Job syndrome. So it can be very deceptive. And again, you have to you really need genetic testing in cases like this to really clarify what the underlying condition is being caused by. So I wanted to talk next about air deficiency. Air, the autoimmune regulator, was really an eye-opener about how a single gene can cause loss of tolerance for endocrine tissues. If you think about it, in the thymus, during the T cell education process, you have to have expression of antigens from different tissues in the periphery so that those T cells can, so that autoreactive T cells can be screened out. And it turns out that air is part of a transcription factor complex that's essential for the expression of certain endocrine antigens that are required for T cell tolerance. And if you don't have this protein, T cells leave the thymus that are reactive against your own endocrine tissues. So the condition, of course, has been called by different names. It was originally called this clunky acronym EGYSIR, but also called autoimmune polyendocrinopathy syndrome 1. And it's a polyendocrinopathy. Almost always the patients present with hypoparathyroidism. They then develop hypoadrenalism, sometimes other endocrine issues as well. Interestingly, they also tend to get chronic mucocutaneous candidiasis, which could be extremely severe. That was a real puzzle until it was discovered that the reason is that the patients are making autoantibodies against neutralizing antibodies to TH17 cytokines. And that is the reason. Presumably this air protein also has something to do with tolerance to these cytokines as well. And so mucocutaneous candidiasis, chronic mucocutaneous candidiasis, is now known to be linked to TH17 immunity. And it's interesting, you can see a beautiful correlation of this type of disease with any type of defect in TH17 cytokines. Autoimmunity, neutralizing autoimmunity to the cytokines themselves, defective TH17 cell differentiation, as you can see in some of the hyper-IgE syndromes, and in a gain of function mutation in a gene called STAT1, loss of function mutations in TH17 cytokines themselves, and loss of function mutations in the cytokine receptors or their signaling components. So it's really a beautiful story, and we understand a lot more about how this works now. Not to say that we understand everything, but it really clarifies. I next wanted to talk about autoimmune lymphoproliferative syndrome and some ALPS-like syndromes, and because they can also, they could also masquerade as a primary rheumatologic problem, something that could walk into the office and might make you think that there's something else going on. If you're a hematologist and you see something like this, you're thinking lymphoma. But if the patient comes in, and as many of these patients did early on, before this diagnosis was, before this whole process was identified and characterized, they always presented with cytopenias. They all had their spleens taken out, and many times that would help the problem, although it might not completely. Depending on how severe it is, it can be extremely severe and difficult to control without the proper medications. Again, it's not really in most cases it's not really an immunodeficiency. It's a problem with autoimmunity, and it's caused by a defect in apoptosis, in which there's defective T cell cell death that results in persistence of T cells and eventual autoimmunity. There are a number of laboratory abnormalities that are typical for the classic patients with ALPS. There's usually a lymphocytosis of both T and B cells. There's an excess of so-called double negative T cells, and these you have to be careful are the TCR alpha beta T cells, not gamma delta. Many gamma delta T cells are double negative, and sometimes if you have a large number of gamma delta T cells, that could be deceptive. But you have to measure the double negative T cells in the TCR alpha beta positive. Anything more than about 1.5 to 2.5% is suspect. And many times these patients have really generous numbers like 20%, 10%, not any kind of minor differences. They're usually hyperimmunoglobulinic. As I said, they almost always present with autoimmune cytopenias, and they often have elevated serum IL-10 and serum B12 levels also. So those are all things that people use in panels to try to identify them. Nowadays, of course, we can do genetic testing and identify many of these patients. However, I will say, so this is a cartoon basically showing how this works. The FAS CD95 is one of the most common mutations in FAS is one of the most common. They can be either dominant or autosomal recessive. But one of the tricky things is that you can have a subpopulation of hemopoietic cells, a hemopoietic clone, which has developed a somatic mutation that can cause this disorder, and it may not be detectable easily using using blood or somatic DNA. It really requires deep sequencing to identify these clones sometimes, and so it can be a very difficult proposition. If you can sort out the TCR alpha beta double negative T cells and sequence them, you have a better chance of identifying mutations in cases like that. Anyway, there are a number of genes in this pathway, which is called the extrinsic apoptotic pathway, and it has been found, and we've had very good luck with this ourselves. Many centers now use sirolimus or rapamycin, which is an mTOR inhibitor, which helps to control this out-of-control cellular proliferation. It really can produce a very beneficial control for the patients. There are a number of genes that have ALPS-like features. We don't know them all. We just lost a patient within the past year who had raging autoimmunity and an ALPS-like phenotype, and we were not able to identify the underlying cause, even with exome sequencing. But there are many genes which sometimes, not always, in some of these genes, for example, CTLA4, which I'm going to talk about in just a minute, 100% of the patients who have CTLA4 haploinsufficiency have an ALPS-like phenotype. But with other genes, the proportion of patients with mutations and this type of phenotype varies considerably. But you can see there are lots of genes involved. So the possibilities are very large. Two genes, CTLA4 and LRBA, make up almost half of these ALPS-like patients. So the chances are excellent that if you have a patient like that you may have a patient who's got mutation in one of these two genes. Just as a reminder, CTLA4, of course, is a down-regulatory molecule that competes with CD28 for T cell activation by CD80-86. It has a higher affinity. It comes up after T cell activation. So after the initial activation, it's supposed to come up, compete away the CD80-86, and allow the T cell to calm down a little bit and allow the activation process to slow down. But if you're haploinsufficient, you don't have enough CTLA-4 there. And this activation is out of control. You really need both alleles working. LRBA is a protein that's involved in shuttling or controlling the shuttling of endocytosed CTLA-4 to the lysosomes. It inhibits the shuttling of CTLA-4 to lysosomes where it would be degraded, and permits it to be recycled to the surface. So if LRBA is missing, you essentially have a secondary CTLA-4 deficiency. And LRBA is a complex disorder that has a lot of other features as well, but one of its characteristics is that it resembles CTLA-4 deficiency. The nice thing about this is that abatacept actually is a very specific treatment that works pretty well a lot of times in patients with this. You're basically giving the patient extra CTLA-4 that helps replace the deficiency they have. So if you can identify this in a patient and you have access to that drug, you potentially can provide life-saving therapy. Although patients can be sick enough so that they many times will go on to hematopoietic stem cell transplant anyway. In the last couple of minutes here, I'll just touch on the hemophagocytic syndromes. Many of you will be familiar with these. I think the rheumatologists everywhere in our institution and everywhere are consulted on this condition, which, as you know, it's a cytokine storm. It's often caused by defects in granule formation, secretion, or function, although other functional defects in T cells can also produce the same effect. But many times we find that NK cells and cytotoxic T cells are deficient in their ability to kill viruses. In early infancy, it presents with this hemophagocytic lymphohistiocytosis, or HLH, which is lethal and really requires bone marrow transplantation after an initial heavy immunosuppression just to save the patient. In older patients, this more or less the same process is macrophage activation syndrome. And what we're finding is, and the criteria that most of you all are familiar with I'm sure, and this is rather old, but I think a lot of these criteria are still quite valid: fever, splenomegaly, cytopenias, hypertriglyceridemia, low fibrinogen, meaning that the sedimentation rate is deceptively low, hemophagocytosis, low or absent NK cell activity is common. Elevated ferritin, and ferritins over 10,000 are virtually pathognomonic for this condition. Soluble IL-2 receptor is also often elevated, or usually elevated, you could say. There are a lot of genes associated with this. I'm not going to go through it, but for the purpose of practitioners, and one of the most important ones is, I don't think it's on here. Let's see. Oh yeah, PRF1 causes probably about 40% of primary HLH in infants. Perforin is essential for granule function. So the granules are made properly, they're secreted properly, but you can't get the granule contents with granzymes inside the target cell. So essentially you're shooting blanks at the target cell without perforin. So, but there are a whole variety of different genes that can cause this. This little cartoon is basically showing that many of these genes are associated with granule formation, as in LIST, which is the gene responsible for Chiari-Higashi syndrome, AP3B1, which is a gene involved in one of the types of Hermansky-Pudlak syndrome, RAB27A with Griscelli syndrome, and then several other genes that are associated with docking, priming, and fusion of the granules so that they can reach the target cell. The important thing for practitioners is to realize that more and more these genes, and not just these two, but others, are being identified as milder forms of the same condition that are responsible for late onset macrophage activation syndrome and macrophage activation syndrome in patients with, for example, systemic onset juvenile arthritis. I think I'll skip through this cartoon. I was going to touch on complement in the last 20 seconds. I think I'm a little over my time here. I apologize. But of course, complement, don't forget the complement system. Early classical pathway complement defects are strongly associated with autoimmunity. It's easy to test. You don't want to miss it. And you can have activating mutations in C3 that can cause C3 glomerulonephritis. You can have defects in factor H that can also cause big problems with activation of the alternative pathway. So it's a good idea to check the alternate and classical pathway hemolytic assays or equivalents to make sure that there are no obvious defects in complement function. So in summary, immune dysregulation with autoimmunity and inflammation, it's often associated with different inborn errors of immunity. Still probably only a small proportion of the patients that would present in a rheumatology practice, but it's a good idea to keep it in mind that a patient might have an underlying defect of this type, particularly if the patient has a history of infections. And it's always unfortunate when the patient's been on B-cell ablation therapy and heavy-duty immunosuppression, and then we begin wondering, gee, I wonder if this patient might have had originally had an immunodeficiency, and it becomes a little more difficult to figure out. The best time to do it, if you can, is before you start treating the patient, to make sure their T and B cells look normal, their immunoglobulins look normal, their complement function looks normal before starting on some type of some sort of therapy for a rheumatologic problem. So thanks very much for your attention. I apologize for going a little over my time. I also apologize for not being able to be here in person, but I'm happy to answer questions by email, and I hope you enjoy the rest of your conference.
So طبعا تسجيل, this is a recording. So we come to the end of our review course for this year.